So when I'm thinking about this from my standpoint, and what I think I see in some of the patients is that people are often worried about the wrong thing. They're worried about the short-term meaning of the symptoms, like, oh, do I have cancer, or oh, did I have cerebral palsy, or rather than the deeper implications, which is a much harder kind of work to do, but there's no orientation in the medical system to think that way.
Right.
So the action of the clinical encounter is really focused on alleviating the immediate question, like, no, you don't have cancer, or no, you don't have a fracture, or this isn't cerebral palsy, or it isn't multiple sclerosis, or something like that. And that the harder question is how to generate attention to the more important questions that the symptom is communicating in the medical setting or as a clinician.
I have something to say about that. We talked about it this morning in the class that went on this morning, and also in the class I've been teaching on Tuesday called GEMS, this new medical system. So the point here is that we're born with two natures. We're born with a material nature, and we're born with a spiritual nature. And one of the things that I brought to bear this morning was one of the limitations, severe limitations of the medical model, is it doesn't honor the spiritual nature of the individual. The spiritual nature means all these other things we were talking about: his social existence, his moral existence, and all of that. The focus is imbalanced in an imbalanced way. Too much is too much. There's too much emphasis, too much focus on the material. But it is the model. The model is too swayed and too heavily focused on the material life. So there's a dishonoring of the spiritual nature, which includes the emotional and the mental and the social and the moral. It's not part of the educational system. The remedy is to bring that in as an educational piece to medical training and medical teaching in the curriculum of the medical schools. It has to be. Otherwise, it's not a whole system. It's not a system that involves healing and health and wholeness and holiness. The root of the word, the root kalo in the English language, K-A-I-L-O, the Greek root, gives rise to the words whole, heal, health, and holy. And you can't have a system that's a completed system, an integrated system, without the holy. And it's not, and that intangible part, that part that's not subject to quantitative analysis, is left out. And so there's only a portion that you can deal with, and that's going to be a problem-solving portion, which you're going to try and affect through the giving of medications and the other kinds of physical interventions, but you're not dealing with the wholeness of the individual. You're not honoring his spiritual side or her spiritual side. And that was thrown away 450 years ago when the medical model as it exists now was first created. And they threw out the rest, which existed before. Before 450 years ago, it was part and parcel of the medical system. And if you look up the word medicine, if you look up the root, med, M-E-D, you're going to find, I found about 11 words that grow out of the same root. So 11 words. Measure, to be measured, meaning to be balanced, not to be immoderate. The system that's too much is too much and focuses so exclusively on the material is immoderate. Remedy, there are many more remedies that are available than the system would avail itself of to use. Lisa's in the position now where they are getting some understanding that there are other things that can be done, like using hypnotic intervention and so on. So they realize that there are other kinds of remedies that can be accessed, right? Mediate, to be a mediator is to stand between. Moderate, to be moderate, modest, modulate, melody, accommodate, modify, meditate. So, medium, midpoint, balance point. It has to come back to a balance point to honor both sides. If that doesn't enter into the system, then they are exquisitely focused just on the solution of a medical problem, being physical, with a physical intervention. And of course, as it's understood, that many physical interventions like medications, as you solve the problem of doing that, creates more other problems. So you give an antibiotic for an intestinal, bacteria, whatever is going on, and you load the person up with a Z-Pack or whatever it is, and then they develop a problem because the antibiotic killed the flora, and now the flora is now subject to another infection, and so on. So there are always what's called adverse, they call it side effects. There's no side effect to a medication. Its effects are its effects. But there's always some adversity that begins to take place somewhere else in the system, and so on. And then you have to try and intervene with that. And you intervene with that, there's another issue that grows out of that. On and on it goes. Because you haven't dealt with all of this. And you need to deal with all of this. And so it's, I think, interesting because Sharon is in a position now where she's a professor of medicine. Now she's getting a new education dealing with emotionally disturbed people. And I'm sure that she's finding that when she deals with these emotionally disturbed people, she's seeing that there's a lot of physical illnesses. There's a lot going on physically and emotionally and mentally. So now she's seeing the physical, emotional, and mental side of it. If she were to go further, she could find out the social disturbance that's going on in that situation. And then we would get to the moral disturbance. Because insane people see themselves as unclean. The word insane means to be unclean. Sane means to be sanitary and clean. So they don't dress cleanly, they don't wash themselves, they're unkempt, their hair is dirty, they have dirty thoughts all the time, they're constantly thinking dirty thoughts. But there still needs to be this education to get a larger sense of the picture going on in a person's life. You need to do that. What Sharon is kind of indirectly alluding to, she was only allowed to spend X amount of time with the patient. Spend by the insurance plans, whatever. You can only spend 10 or 11 minutes as an internist with a patient. What are you going to learn? In 10 or 11 minutes, when your focus is supposed to be on taking a physical exam, that already uses up the 11 minutes. So you can't get to all of this. And then you have to go on to the next person, 11 minutes. Then you got to write it all out. And it becomes a absolutely excessively laborious task where you don't have time. Right? A dermatologist, the average time a dermatologist spends with a patient is 3 minutes. 3 minutes. And not to ask any questions about the skin and what's getting under your skin, what are your thin skin about, who's getting under your skin, and so on. What's the eruption from? What's the emotional eruption that's connected to this, and so on. None of that's done. So that's what's necessary. That's what we were looking to do here, to bring a larger scope of understanding the whole experience.